I'm going to tell you a little bit about my doctoral research that I've defended in January this year. And it was on the evaluation of the implementation of integrated care for chronic diseases in Belgian primary care. So to keep it short, the title was Let's Get Organized, because we found that good organization is really key in order to be able to implement integrated care in primary care practices in Belgium. I'll first let you know a little bit why I picked this research. I'm trained as a general practitioner, and I started in a rather small primary care practice near the place where I was grown up. And we were 4 GPs, including me as GP in training, and 1 secretary. And I liked to practice a lot. I learned a lot, but I also remember that when I had a patient with diabetes, very often these were difficult consultations because our electronic health record wasn't up to date. I had to scroll back in order to find what was the last time my patient had a lab test or a urine sample, and so on. So there wasn't really a good organization to follow up these patients. I even remember once that I told the patient, you should have a urine sample because you have diabetes and that's important, and that the patient looked at me as, what are you saying? I have diabetes. I do not have problems with my kidney. So although this is a very important test, patients weren't really aware. Then in the second year, I moved to a community health practice where we are a much bigger team. And currently we have, I'm still working there, we have 8 GPs, 10 nurses, we have 8 secretaries, we have a dietitian, and so on. And their care was organized completely differently. The patient visited the nurse every 3 months, and she had a very organized way to follow up the patients, and that was I muted?
Yeah, you're back now.
Yeah. Okay. I don't know where I was when I got muted, but so I started in a small primary care practice with just GPs and a secretary, and then I moved to community health center, and there the organization of care for patients with diabetes was much better. And this led me to think, how can we make sure that all patients in Belgium get this good diabetes care, and is it really better? So that's what motivated me to do this research. I didn't do my research on my own. We were part of a bigger consortium. It was called the SCUBY project, and together with colleagues from Slovenia, the Netherlands, and Cambodia, we looked at similar challenges. And you can find all our outputs on the website of the Institute of Tropical Medicine here displayed. So what is it then concretely, the problem? When we look at Belgium, it's the case that 1 out of 10 people has diabetes. That's already many people, but a number that I think is even more striking is the 1 out of 3 that doesn't know they have diabetes. So that's really a lot, and these patients can be treated as they don't know their status. And then the other 2/3, the question remains, are they treated as it should? So diabetes is rising in Flanders, which is a part of Belgium. And especially if we look at the gap between the more vulnerable and the less vulnerable people, we also see that this gap is big and also rising a bit. How do we measure this vulnerability in Belgium? It might be important to understand what's coming next in my presentation. We have something that's called the increased reimbursement status. It means that patients are entitled to get more reimbursement of health services, and they get this status when they are vulnerable, such as if they are in poverty or if they have multiple diseases, they can get this status. So maybe you think Belgium is a high-income country. Patients there, if they know they have diabetes, they will be followed up well. Well, that's also not the case. If we look at adults with diabetes who do not use insulin, so type 2 diabetes patients, only 17% has adequate or appropriate follow-up. What does it contain? It's having an HbA1c test, a cholesterol test, a creatinine test in the blood. It's having this urine sample every year and a consultation with the ophthalmologist. And only 17% of patients is followed up well. But then maybe you think, even if they are followed up well, they might be treated well. Also, there we have some problems in Belgium. When you look at the potentially avoidable hospital admissions for diabetes, you can see that the blue bar, the blue dots, which is the EU mean, we mostly follow these, although we are a very high-income country, and for most indicators, we score higher than the EU mean. But for following up chronic diseases, we don't. And even in the 2 years, the 2 latest years, we do worse than the EU mean. But luckily, there is some kind of solution for all these issues with NCDs. And one of the models that's already developed in the end of last century is the chronic care model. And the chronic care model has different elements, such as decision support, community linkages, self-management, delivery system design, clinical information systems, and the broader healthcare system. And if in all of these elements care is organized well, you have a better prepared and proactive team and a better informed and activated patient, and it has been proven that this leads to improved outcomes. Which brought me to my research questions. The first research question is, what is the current level of quality of chronic care, in primary care specifically in Flanders? And then I already tell you the current level isn't that high. We looked at the barriers, but also the facilitators towards this integrated care for chronic diseases. To understand a little bit better my research, I'll have to explain you somehow some features of the Belgian healthcare system. What is important? We have therapeutic freedom for physicians and freedom of choice for patients, which means physicians have a lot of autonomy to organize their primary care practice as they prefer. Also, 99% of population is covered for a quite broad benefits package. But this therapeutic freedom and freedom of choice for patients also means that there is no clearly defined gatekeeper function in Belgium. So patients are free to visit any GP they want, or the physician in the hospital, and then another physician if they prefer. It's all reimbursed. Although there are some measures to stimulate patients to have their own GP, and most also do. If we look at the financing model for primary care in Belgium, there are 2 distinct models. So it means general practitioners can choose which model they belong to. Currently, there is also a 3rd model, but this wasn't existing yet during my research, so I'm not discussing this 3rd model. The 2 main models are the fee-for-service model. This is the classic way in which patients go and visit their GP, and then their consultation is reimbursed by the health insurance afterwards. Next to that, there is the capitation model, and there patient subscribes to a certain primary care practice, and then this primary care practice receives money from the health insurance every month to take care of all the patients that are subscribed, regardless of the fact if they show up to get care or not. The models are different. Most physicians choose for a fee-for-service model, so there are also most patients. But the capitation model is also important. Previously, the fee-for-service model was mostly single-handed practices. This is ancient times because currently more and more GPs team up in groups and they also take on other healthcare professionals and they become multidisciplinary. In the capitation model, it has always been multidisciplinary teams. Also, it's the case that these practices have been existing more in deprived neighborhoods. So then the question was, how do primary care practices implement this chronic care model? And therefore, we could look at the two primary care practices that I started, the smaller one in the first year and the bigger one, the community health practice, which was a capitation practice in the second year. But of course, we looked at many more practices. We sampled 66 in total. And we grouped those 66 in 3 groups. We made a distinction first on fee-for-service versus capitation practices, as I explained the difference. And then we also made a difference between monodisciplinary and multidisciplinary practices. The monodisciplinary practices had a GP. The multidisciplinary also had a nurse or a dietitian because this was important for patients with diabetes. There were no capitation practices that were monodisciplinary, so we ended up with 3 groups. And we visited these 66 practices with a team of researchers, and we we interviewed them, and afterwards we filled the ASIC questionnaire, which is based on the chronic care model and measures the implementation of the chronic care model, and as such the quality of chronic care. We always did it with 2 researchers. We scored separately, and then if there were differences, we came to a consensus score. And we also made field notes to have some qualitative data to also explain a bit. What we found is that monodisciplinary practices scored lowest on all the elements of the chronic care model we measured, followed by the multidisciplinary group practices, and then the capitation practices. But still, in all practices, as you can see, there is still a big gap between the capitation practices and the maximal score, so there is room for improvement for everyone. Next, we dived a bit deeper into the statistics of these scores, and we found that nurses had the highest impact on the score. So having a nurse was most influential when you wanted a higher score. This was followed by the financing system and then having a secretary. Although we didn't really interview the secretary also, but we did find this was an important player. Whereas the dietitians, when controlled for all the others, didn't have an additional significant effect anymore. And this can partially be explained by the fact that in Belgium, nurses aren't reimbursed. So very often the GP takes on the nurse and they pay the nurse and the nurse joins the team meetings, whereas the dietitians, which can get their own revenues, they often rent a consultation room at a GP practice and they aren't invited to the team meetings and so on. They are really a bit autonomous. So this means they also don't really take part in the integrated care. So for the multidisciplinary teamwork, it's very important that the nurse is also integrated, and we believe that also integrating the finances therefore are very important. But when we look at quality of care, these questionnaires is of course not the only way to look at quality of care. The Danhieux model of quality of care outlines 3 elements, which are structure, process, and outcome. Structure, this is what we measured with the chronic care model and the AC questionnaire. But then process and outcome, we've also been measuring that. Process indicators, which means is the care delivered as it should. We measured it with data from the intermutualistic agency, so it's health insurance data. And outcome measures we measured with lab data to know the real HbA1c and cholesterol levels of the patients in our sample. So how did we measure, or what did we find? When we looked at the process indicators, we found that practices with a higher ASIC score also were able to follow up their patients better. They measured more frequently correct the HbA1c and the cholesterol levels of the patients in their practice. So that's already good. That patients, so what we found is that certain practices do better on the chronic care model. We also found that they also do better on process indicators. And as I told you, we also had some qualitative research to it. And there we looked at why are there these differences. And I'll go over all the elements of the chronic care model to explain you why these differences were there. And I also always give some advice for other practitioners in Belgium or abroad. What can you do to improve this care? Let's start. My high scoring practices, so with a nurse, with a fine capitation system, or with a secretary, they had more time for consultation. So the nurses and the dietitians, they spent often half an hour, sometimes an hour with the patient. So they had more time to listen to the patient. Also, really stimulating self-management is a core business of nurses and dietitians. And they also told me that they felt that the patients told them they had less barriers to talk with the nurse or the dietitian about their concerns, whereas the general practitioner was still a bit higher up in the hierarchy, and maybe they had some concerns that they didn't really dare to tell their physician. So what can you do? I think it's very important in self-management to systematically ask about self-management and also make notes in the electronic health record. We are often used to ask about all the medical symptoms and how these are going, but also asking what patients know about their disease and how they are able to manage it is important. There are also a lot of often a lot of other organizations that can support with that, and therefore it can be good to make what we call a community resource guide, which means a list of all the community organizations in your neighborhood, so it's very specific to your neighborhood that can help you. That's also something that helped. Then we move to decision support. And there we saw that practices that scored higher had more protocols and also more educational material for the patients. And especially they contextualize these materials. So a practice protocol is really outlining in our primary care practice, what will the nurse do, how often will we see our patient, when we have a result, will we do a phone call to inform them about it, or will they have to visit again? And if you work in a multidisciplinary team, it's very important to have these protocols so that the roles are clear for everyone. So what can you do? I think follow a training on the organization of chronic care can be very helpful. But also, if it comes to decision support, integrate the guidelines in your electronic health record is important. And adapt educational material. This it's good to look at in the flow of your consultation what's most useful. Our high scoring practices also often had their own leaflets indicating for the patient when they had to come to visit, and this was also something helpful to organize well. if we come to the delivery system design, this is how your internal primary care practice is organized. And there we saw that our high-scoring practices had a lot more teamwork, so they had more team meetings, what I already explained about the nurse versus the dietitian. So they did more teamwork, they had clear roles, and they also made use much more of the concept of planned visits. What does it mean, a planned visit? It means that both the patient and the healthcare professional know that the patient will visit and it will be about the chronic disease. And this is very different than what we see very often happens with the GP. A patient has some kind of complaint, maybe some knee pain, and they visit and the consultation is all about the knee, but then in the end the patient also asks, oh please doctor, can you prescribe me some of my diabetes medication because I run out. And of course you understand that this doesn't really work, or it works but it's not really qualitative care. So therefore the concept of planned visits in which the patient knows I'm going to visit for my chronic disease is very important, and it's much more often with the nurse than with the dietitian, because of course patients know that the nurse cannot really also take care of other complaints. Then we move to what you can do. So you can try to install these planned visits. Even if you do not work with a nurse, you can ask your patient if they ask for these prescriptions. Yeah, that's okay, but please can you come again next week or next month so that we can discuss how your diabetes is going. What you could also do is, it's a Belgian thing, I think, but very often the nurses are used to draw blood, but of course they can also do much more. And if you want to organize well, it can be an idea to delegate this task to the local lab. They also do that. And it practices that try to delegate this task also are able to pay attention more to the patient and what they need. But what's very important is to think what works for me and my practice, and of course in other contexts this will be very different. If we move to clinical information systems, it was the case that our high-scoring practices had a patient list very often. They could make that, whereas in many other practices they weren't really able to draw a list of all the patients with diabetes, for instance. Where as in the high-scoring practices they did do so. And also really good reminders. That when you opened the file of a patient, you could see what still needs to happen. So what can you do is try to make such a register, a list, and it will already learn you a lot about your diabetes population or any other chronic disease. Also, it's important within the primary care practice to agree on how to register diagnosis and to use these reminders in a way you find it useful yourself, because you can also have reminders by the system, but then often GPs tend to claim it doesn't really help. So it's important to program them so that you find them useful yourself. Follow educational sessions with the software provider can help to do all of these things. And then the last element are the community linkages. And there are primary care practices that scored high. They referred much more often to initiatives in the neighborhood, and specifically the community health practices had a health promoter. That this is a healthcare practitioner, a staff member, which was their task to really link up with organizations in the neighborhood to promote health instead of only cure diseases. If we then move to what you can do, it's build a network. And in this network, I think it's very important to try to build, not to look for as broad network as you can think of, but it might be much better to have some close relationships with some organizations or other healthcare workers in the neighborhood that you know very well, that you can refer to, that might also communicate back to you. That's something that's proven very helpful. So I've been discussing how the high scoring practices do better, and I've showed you that they also do better in the way in process indicators. But there was one more thing that we also discovered and that I think is very important, and this relates to equity. So what we saw is that, again, looking at more vulnerable and less vulnerable patients, we saw on the x-axis that practices scoring high, so on the right of the graph, that there was no difference between the more and the less vulnerable patients, whereas practices that didn't score high, this was this difference. And I think this is very important because very often I got the comment when I started this research, yeah, but Katrien, when you do all of these consultations with the nurses and you focus a lot on the chronic disease, that's often good for the worried well, for the patients that really want to come and visit, but it will have a higher equity gap. But our research has proven different. If you are really able on this practice level to implement this chronic care model, which also entails proactive care, which means reaching out to patients that have missed an appointment or that you know from your file that haven't visited in a long time. This really helps for the more vulnerable to get equal care as the less vulnerable. And then we come to the outcome indicators. So that's where it really starts to matter. However, we didn't discover any differences. And there are many reasons for it. They are statistical or methodological. And if you really want to know, I'd like to refer to my PhD thesis discussion in which this is outlined much more. But one of the key things was the fact that in the outcome indicators, so the two bars on the right, we didn't really find differences between practices, but only between individuals and between individuals over time. And of course, one of the explanations is the fact that health is influenced by healthcare, but only to a limited amount. Everything we do in healthcare is important, but still all the other elements that influence health, such as education or poverty, are also very important. And then, since my thesis was defended, we also, after that, we used the data to look a little bit more. And we had one extra research question because we also wondered, these practices that score good, we already know that they are able to follow up patients better. So they have less what we call under-testing, but maybe they're also able to do over-testing. And this is something that can be important for policymakers because maybe these practices can also save some money. And especially for HbA1c, this is important. This is relevant because HbA1c measures the glucose level in the blood in the past 3 months. So if you tested HbA1c and then 1 week later you test it again, this doesn't really make sense because it won't have the time to really change. So we also looked at over-testing. And to explain that, we first have to explain correct testing. So we defined it as having at least 2 HbA1c measurements in a year that are 80 days apart. If you have under-testing, you do not meet these requirements. And if you have over-testing, it means that you did a test too soon again, so within this period of 80 days. We found a percentage of 31 of over-testing and also around 31 of HbA1c under-testing. And then we looked at the association with this implementing of this chronic care model. But of course, there were also some control variables for which we controlled. And there we saw that negatively associated with over-testing was the income in the neighborhood and under-tested. So patients that are under-tested are less frequently over-tested, which is logic. But then there were also some factors positively associated with over-testing, being a rest home resident. So there integrated care is not on point as much as in other patients, but also in patients that visited multiple GPs. So this is also very logical that if you go in multiple GPs, the other GP isn't informed about what the previous one did, so there is more over-testing, as well as the amount of comorbidities and having an administrative status of a chronic disease. We didn't find an association in the final model with type of GP practice or with the city or with the age of sex of the patient, nor with the increased reimbursement status, being the vulnerability. So what was then the relationship between the ASIC score and the HbA1c overuse? We saw that it's not a linear relationship. We saw that practices scoring lowest, so not implementing anything at all, they had not a lot of over-testing. So, but we knew from the previous graph I showed you, they also didn't have a lot of, they did more under-testing. But then when practices were able to have a higher ASIC score up until 5, we saw that over-testing also increased. So they started to think about, oh, we should do better for diabetes patients, and they started to put things out there, but also over-tested more. And once they surpassed the ASIC score of 5, this went down again. So it means that really implementing the chronic care model really well helps for over-testing, but only if you go to the right end of the graph. And it's important to note that the total ASIC score is 11, but we haven't had any samples, had any practices that scored that high. So far, how I measured the current implementation of integrated care for diabetes, but we use really diabetes as a case study. But then came the next question. How come? As I explained you in the beginning, Belgium is a high-income country. We are also kind of proud of our healthcare system. But why is it that this Belgian healthcare system doesn't really perform well, specifically for NCDs? And therefore, I used the rainbow model of Valentine that looks at different levels of care. So it looks at the service level, the professional and the organization level, and the system level. I've been diving in the professional and the organization level a lot. In the last part of my presentation, I will focus on the policy and on the patient level. On the policy level, we interviewed 27 stakeholders, and we asked them, what do you think of the current level of integrated care for chronic diseases in Belgium, and why isn't that good, and what can we do to improve? What we found is a lot of elements. So the stakeholders told us that the current consultation model, which means on the macro level, healthcare practitioners discuss with health insurance and with the government how we should divide the budget. But these discussions are within silos. So the GPs discuss this with the health insurance, and then the nurses discuss this, and this isn't really integrated, which of course doesn't stimulate integrated care. If we look at the political culture, it's also the case, stakeholders told me, that we do not do evaluations enough. In Belgium, we're very good at having a new pilot project here and a new ID there and then a vision document. But then after these pilots are introduced, the evaluation doesn't really follow. Which means, and also not the adjustment, which means we don't really move forward. And the last important element was the fragmentation of responsibilities in Belgium. And I'll explain you a little bit better in the next slide. What we saw is that, or what we know is that the Belgian healthcare is organized both at federal and at federal government and at the level of the federated entities. The federal government is responsible for curative care and paying the healthcare workers, also in primary care and also for hospitals. Whereas the federated entities, they are responsible for long-term care, elderly care, the organization of primary care, and prevention and health promotion. Which means the biggest budget is still on the level of the federal government, and the federated entities have a smaller amount. But the fact that the responsibilities, so organization of primary care is on the federated entities, but paying these primary care healthcare workers is then on federal government. So things that should be together aren't together, and this leads to more fragmentation instead of integration of care. And it's even the case, some stakeholders told me, it leads to some kind of power conflict in the way that politicians on the federal level want to be the best politician and have the best care, but it's the same for the politicians in Flanders, for example, and they, instead of working together, they kind of do not really cooperate and want to be the best one with the best policy. Which then brings me to the people that it's all about, and there are the patients, of course. And I also went to interview patients, and we specifically looked at one group of patients, people with complications. Because if you have diabetes, but you are screened in time, diagnosed in time, and you are treated well, you most probably will not really have important complications. So patients that really have kidney problems, food problems, or eye problems, we guessed they have had some problems on the way. So these patients, we interviewed them. And what they told me was something completely different than what policy makers and practitioners told us before. They focused, for them, other things were important. One patient told me that, well, I didn't know I had diabetes. I entered the hospital with a black toe, so he came in much too late. Whereas someone else told me, I always thought it was a far cry from my situation. Getting treated wasn't important to her. It's not going to happen to me, she told me. And then other patients told me, or the daughter of a patient told us that the moment that the patient lost her partner, she really couldn't think of the diabetes anymore, and it got way worse. Which points to the fact, and it's something we as general practitioners often do, we try to focus on what's important to the patient at that time. And maybe we would say, oh, but yeah, now you have something else to deal with in your life. Let's postpone this diabetes care a bit. But in fact, my research shows that it might not be the best strategy, and it might be good to even in these moments, or especially in these moments, the disease can worsen. So to look into it, because if you have an HbA1c that's too high for too long, you develop complications. Other patients told me that they have a lot of paperwork to do in order to be able to get the refunds they needed. Or also very important is the fact that the healthcare in Belgium is reimbursed very well. So when you go to the physician, this will be reimbursed, but all the costs around it were problematic for our patients. So getting to the hospital was a problem for this patient, but also the material for wound care was often very expensive, or having specific shoes for diabetes, custom made, can be important if you have a diabetic foot, but then they are also only reimbursed at a certain time period. So there was a much more important barrier for those patients. Which leads to some recommendations based on what the patients told me, and that is, I think, strengthening community-based screening, reducing especially these paramedical costs and also the administrative burden, and improving health literacy is also important. During my research, I have there was something very specific that happened that you might all remember, and that was COVID, of course. And luckily, we were able to not let it change or impact our research too much. It's even the other way around. We really used COVID, as you can see, a bit as a magnifying glass to look at the healthcare system. Because when you're in a crisis, you see much better the characteristics of your system and what's going good and what's going well. We did this study together with the Cambodian and with the Slovenian colleagues to look at what are then strengths and weaknesses in our system. And I've already talked a lot about the weaknesses, so I'll get out one of the strengths that we saw, and that is in Belgium, we really have this entrepreneurship. So during COVID, I explained you that healthcare practices, GPs, are very autonomously, they run their own practice, and this helped in COVID, so they were able to change and do for their patients what they could do. But it also could be of use in chronic care. If we could also turn the incentives in the right way, it could be also a strength for chronic diseases, that we could improve the quality of care. So then I think it's always important to discuss strengths and weaknesses of our research. What was a strength and a weakness is the observational. It's the fact that our research was observational, which means we cannot really claim causality. That's important, but we were able, on the other way, to have a really representative sample, which isn't always possible when you do a trial. You get more practices that are really happy to participate. We are the first researchers that have been able to link this chronic care model with process and outcome indicators, but specifically with this equity dimension, which is new. And if we look at our barriers and facilitators, we've been able to get the complete picture from the patient to the healthcare worker and the policy actors. But important is to know that not everything is generalizable, as for the patients, we picked out a specific patient population, so we cannot say something about the other patients. Which brings me to the implications of my research. What we think is very important is to first stimulate the practice nurse in primary care. Very contrary to a lot of other countries, we didn't have this nurse. Like 5 years ago, it was very rare to have a nurse in primary care practices because there was no reimbursement system. Currently, this is changing and much more practices are having this nurse, but we think it's very important. If we talk about financing systems, it's important also to integrate them. Whether it's capitation or fee-for-service, you can discuss, but if we look at, for instance, the dietitian that doesn't really integrate in the primary care practice, it's much more important to integrate financing systems. Building better monitoring systems is also very important. It has been very difficult to get the data. It's already late in our project that we were able to get them, because we only have, in Belgium, we only have insurance data, and this data isn't really meant to monitor diseases. So if you want researchers to monitor the status of our population, we also need better monitoring systems. And lastly, I think a lot of the practices that I spoke to were very happy to do better. They wanted to improve, but they didn't know how, or there were other barriers. So I think it's important to support those primary care practices in this change, which also leads me to explain a little bit about the current project I'm doing, which is the JACARDI project. It's the Joint Action on Cardiovascular Diseases and Diabetes. It's a very huge European project with a lot of pilot projects, and we have one of them. And what we do is we really stimulate these primary care practices through workshops and an online platform. we try to teach them how they can organize this practice. So everything I told you, what you can do, we spend a lot of time on them to make their own practice protocol in order to implement all these elements of the chronic care model. In this way, we hope to, together with other changes that are happening on the macro field, to really improve primary care practice for chronic diseases. Which was my last, last thing I would like to tell you. If you want to find more information, the doctoral thesis is open access on the website of our university. You can scan the code if you want to find it. And if you want to be updated on our current project, you can also find our website. So that's it for today, and then I'm very happy to listen to any of the questions.
Thank you very much, Katrien, for a wonderful insight into the implementation and organization of primary or chronic care in primary care in Belgium. I think we've all learned a lot and can apply these to systems in our countries. And congratulations on very relevant and well executed research. So if anyone would like to ask Katrien a question, please raise your hand and we'll go from there. So I see Jan has already raised his hand. And while we do the questions, I'm just going to share a slide with our future webinars that we have coming up. But yeah, Jan?
First of all, Katrien, congratulations with this beautiful overview of the work that you did. And I think it's very relevant work because it's grounded in a diversity of the actual health system and looking at those things that make a difference and see what you can learn for policy perspectives. There's one feature that you mentioned in your talk, but that you did not go into detail in, and the fact that there is no gatekeeping in Belgium. And I think that's an important factor because we see that a lot of patients with type 2 diabetes, even those that are not on insulin, they regularly are followed up partially by their family doctor, but also partially by their specialist doctor. Do you have any idea about the frequency of the contacts the patients in the different settings had with specialist doctors and how this can eventually have influenced the findings, or did you come across some interesting qualitative things with relation to the gatekeeping? Because it's a debate that we started 50 years ago in Belgium, but we did yet not finish it. And my personal view is that we should rethink the importance of gatekeeping, certainly when it comes to chronic care. Thank you.
Yeah, we haven't looked at it in the data. I agree with you that it would be very interesting and it might be some additional research we could do. But from the qualitative part, I also do remember some patients that told me that they weren't really happy with how their GP took care of them, or that the GP had some clinical inertia so that they waited a long time, whereas in secondary care they were treated better as they preferred, and they even disliked the fact that they had to go to the GP once a year to get the reimbursement. So I think although it's something that can improve continuity of care, and I think of course that the role of the GP is very important, but I'm a bit afraid that if we want to implement this in the current system, where already now GPs are overburdened, it's not now the time to do that, I think, because they will have a lot of more tasks, and they will be very, yeah, they won't be in favor of this, I guess.
Of course, I'm happy to disagree. I think that when GPs use appropriately the support and do task shifting towards nurses and towards practice assistants, they will not be overburdened. And I think sometimes in Belgium we don't think sufficiently out of the box. So we reproduce looking at actual symptoms, and we know that for every patient you need causal therapy. You have to look at the upstream causes of illness and disease, also of your health system. And of course, it is absolutely nonsense that people with 11 years of academic training take care of patients on metformin with quite appropriately regulated diabetes type 2. That's an inappropriate use of your resources in your healthcare system.
But I think when you want to implement something, it's not, even if I interviewed the stakeholders, this was not the thing that came up as a way to move forward first. So there will need a lot of, you will need to massage a lot of people in order to get this really able to implement it.
Or maybe you need a minister that's more a surgeon than the classical
that's
politicians.
Another way.
Yes. Okay. Thank you.
Thank you, Jan. Is there anyone else in the audience that would like to ask Katrien a question or comment?
If not, I have another question. This is a vertical disease-oriented program with a specific financing system. We have 2 in Belgium. That's this one and the one on chronic renal failure. We had planned 12, but we did not do the 10 others. And I'm still convinced that it was a very good thing not to do the 10 others, because today the issue is more and more multimorbidity. And you, of course, in Jakarta, you see it with your diabetes combination with cardiovascular risks. Yeah, there are a lot of people that have both. And so that raises the question, should we not go to a more generic approach than to these kind of vertical disease-oriented approaches? And European countries have made different choices in that. The Portuguese, at a certain moment in time, they made a building for every disease. So I think they have something like 10 of these buildings where then all the knowledge about a certain chronic condition is in. And we stopped in Belgium in 2010. What is your idea? Because that's a debate in Europe. Which way to go? Do we have to go for the vertical approach, disease-oriented, or should we go more broadly for a kind of generic approach towards people with chronic conditions?
Yeah, so we used diabetes as a case, as I told you. So we didn't only look at the disease program, we looked at how diabetes was treated within the GP practices, because it was a good example. You always need some, when you're going to measure diseases, you will always need to pick something. It's very hard to, if you want some indicators, you will have to define something. But that said, I do think that it can be in a primary care practice a good step up to start with, to try to organize differently with the nurse and with all the things I explained. And then I think a next step is to really have other diseases with it, and then it becomes multidisciplinary. But you need something tangible to learn practitioners to do something, to organize differently. You need to start somewhere, I think.
Yeah.
Thank you. I could not agree more. Thank you very much.
And I see, Alec, you've turned on your camera. I'm not sure if you wanted to ask a question.
Hi, hello, Alek Biesiada from Poland. I'm a general practitioner. I do work within Polish Society of Family Medicine. Thank you very much for the great presentation. This is something that we are working here in Poland on. And I do not agree that you need a surgeon at the highest level of the ministry. You need someone who can count. And then obviously taking care of patients on the lowest level of the healthcare system is just cheaper, and this is how we try to approach this. And this is maybe something different from my perspective, that we are more focused on the accessibility to the health care system for patients, especially in rural areas where due to coordinated care and easier access to new diagnostic tools and consultations between doctors, between general practitioner and between specialists, specialized care, we can achieve that. And also the second thing is that at the end, also the time is this is quicker for patients, so it's less time consuming to organize this kind of care. And then my question is, do you have the knowledge from that perspective, that the patient's perspective of time, of waiting time, and the accessibility to the system?
Yeah, if we compare the different, that's hard because then the system has grown. So it's hard to say that the one is more accessible than the other. If we look at yeah, because accessibility can mean multiple things. It can mean that so as I told you, practices are very autonomous, so they can decide to shut down if their patient list is full. They just take no new patient, and if this is the case in your neighborhood for multiple practices, then you have a problem in terms of accessibility. On the other hand, if it means you have to wait some time to get to the GP, it's also problematic. But in Belgium, it's still the case that if you have a GP, you contact them with an urgent problem, you will be seen. They will not tell you you have to wait for a week. So we don't have this issue yet. It's much more problematic, especially in some regions. The problem is much more that if you move, you don't find a GP because they are all full. And then sometimes patients keep their old GP, they go back to the place they lived before, which also doesn't help in that place. But yes, in rural places, there are a lot of patients without a GP, and this can be problematic. Which also referring back to Jan, would need some kind of change if we want some gatekeeping system. These are the patients that then also visit the hospital because they cannot find a GP. So we need, if we would put gatekeeping there, we would need to solve that too.
Oh, these are the same problems everywhere.
Yeah.
Right. Any more questions? I've got another minute or so left.
Oh, hi. Hello. Actually, so I'm Annika. I am a researcher based at the University of Cambridge. I'm actually going to do a PhD. Well, I'm applying for a PhD similar to the topic that you did. So it's about integration between, but more specifically between GP and a hospital neurologist. In terms of routine care for neurological patients. So we actually have, because of COVID, we got the teleconference. So we just use MS Teams to have a chat about referrals. And so I just did the interviews with the clinicians and the system leaders. Again, we face issues in terms of financing. So who is going to pay for this joined up initiative? So I think what was interesting is your comment about equity, that you said that this model of care actually reduced the health inequality. But I don't know whether you reached that conclusion just by, is it just by talking to participants, or did you actually collect some outcome data, or how did you assess that?
It's on the process indicators. So we know of all these patients in those practices, whether they were vulnerable or non-vulnerable. So it's 0 or 1. And we saw that in the high scoring practices that the gap wasn't there in between those. So it's really hard data. It's not on it's not on qualitative data. It's really on the quantitative data.
So actually measuring the patient outcomes, is that right?
Yes, but not the hard HbA1c, but the processes. whether they were followed up well. So it's a hard outcome, yes, but it's not an outcome indicator.
That's really useful. Yeah, thank you. So I think that there is evidence to say that when you have these kind of chats between GP and specialist, you are actually reducing the health inequalities because the GPs could present those patients well, like, you know, patients who are living remotely, elderly, frail patients, so they can get these points across much more quickly. That's kind of what I've learned from other studies. So I'm about to do one for myself for later.
Okay. I
Yeah.
hope you can also find something similar that to reduce inequalities, because it's very important.
Thank you.
Well, thank you everyone for joining, and thank you once again to Katrien for your time and your wonderful presentation. And we look forward to anyone else who would like to join us in our future webinars over the next month. I've advertised them here. Otherwise, you're always welcome to get in contact. And if Katrien, if someone wants to get hold of you, they can always go via me, and I can put you guys in contact. Right. Thank you, everyone.
Bye.
Bye.